So I'm delighted to introduce Dr. Iris Zachary today. Her research is focused on cancer informatics and surveillance and public health informatics to maximize the use of data to improve health outcomes. She is the director of the Missouri Cancer Registry and Research Center. Dr. Zachary's cancer research collaboration aids the study of cancer diagnoses patterns and evaluation of cancer prevention plans. Dr. Zachary leads the graduate certificate program for informatics for public health, with continued work and collaborations to connect communities, organizations, and stakeholders through informatics tools and information technology to build capacity to respond to and prepare for future public health challenges and opportunities. Dr. Zachary received the 2020 Ann K. Covington Award from the MU Fellowship Office, which recognizes faculty mentoring undergraduate applicants for nationally competitive fellowships. She was awarded the Health Informatics and Information Technology Section, American Public Health Association 2017 Outstanding Leadership Service Award, and was selected as MU University Faculty Scholar in 2014. And with that, I will welcome Dr. Zachary. Thank you.
Thank you for the introduction, Mary. Good afternoon, everyone. Thank you for coming this late in the day. I will talk about mainly cancer surveillance informatics, the Missouri Cancer Registry and Research Center. So after you leave here, you will know what Central Cancer Registries do, what cancer registries are, and then how we can leverage the Missouri Cancer Registry on campus, specifically at the University of Missouri. So just a little bit of background. Cancer surveillance looks specifically at cancer trends. We are collecting cancer cases, making sure that we monitor trends. We look at subtypes of cancer, and we'll look at cancer clusters. There's a cancer inquiry that takes place if there's a heightened community alert or there's a heightened number of cases in communities. And we also influence or provide data if there's policy changes that need to take place. Cancer surveillance informatics specifically focuses on identifying technologies and the electronic data, for example, electronic data exchange, or the processes that need to happen to make cancer surveillance basically functional and happening nowadays in the field. I always say we have done cancer informatics or informatics in the field of public health for a very long time, much longer than we had a name for it. Public health has done informatics over 40 years, 40, 50 years already. So we have a name for it now, and there's now a little bit more funding after we had our crisis. We're still in the middle of it, but there's finally federally enough, there's enough attention that is paid to public health so we can actually do our work. So a little bit of background, so you know what we're talking about when we're talking about cancer registries. There's different types of cancer registries, hospital or facility-based cancer registries. So for example, here at MU is Alice Fischel, that's a hospital-based cancer registry. There's also population-based cancer registries, which are referred to as central registries. So the Missouri Cancer Registry is a population-based central cancer registry. We are funded by SEER and MCR, so your registry is either funded by SEER, which is the National Cancer Institute, or by NPCR, which is Centers for Disease Control. And you have a cancer registry in every state. So every state has their own central cancer registry, which is makes for a lot of collaborative efforts with states, so with other states, because we are technically not really in competition, so we can actually do a lot of collaborative work together, and we share a lot of progress together. So it helps in terms of funding, so we're not competing, we're competing for funding, but we're not competing against each other. Then also there's specialized registries which are disease specific. So this is just a map so you get an idea. NPCR and SEER registries cover over 100% of the United States. And this is, to give you an idea, so NPCR is the blue, and the green is the SEER-funded registries, and then the lighter registries are both. So you want, and that will become important later on in my talk, you want to be both. And you're heading, hopefully, towards that direction also. There's a lot of diverse sources and a lot of variety in data that we receive in the cancer registry. So originally, 20 years ago, our main source of reporting came from hospitals. Nowadays, we receive cases from clinics, any clinics, physicians, physician offices, pathology labs, some NextGen sequencing labs. We get federally, we do federal linkages with federal agencies, NDI, SSDI, and IHS. We also get our data from death certificates, and we do out-of-state data exchange. We are now part of the national data exchange, which covers 80% of the United States. So what that means is if a Missouri resident is diagnosed somewhere else, for example, if they spend 6 months of their time in Florida or in Arizona, and they get diagnosed there, they are still a Missouri case. That's what data exchanges do. So like we still get that case and count that case as a Missouri incidence. Legally, Central Cancer Registries are required by law. It's by Public Health Authority. We are exempt from HIPAA privacy regulations. That doesn't mean we still follow HIPAA regulations, but it just means we don't need a specific HIPAA waiver. And registries have to protect confidentiality and privacy. Like I said, we still follow all the HIPAA guidelines. Registries serve as honest brokers for the data. They can provide de-identified data to researchers, but in Missouri, we have additional protections for the patients and for anyone in the cancer registry. So it's actually a little bit harder. Sometimes that makes research a little bit more difficult and a little bit more lengthy, but it's to protect really privacy of the patients. HIPAA overall does not obstruct any state law that supports or mandates the reporting of disease or injury for public health purposes. So like I said, HIPAA is not in the way for us. Written informed consent from each cancer patient is not required, and what I mean by that is not required to be in the registry. Now it is required if there's, for example, a research study or anything that is going on where data is requested from the registry, the patient would still be informed. Also, as basic understanding or background, there's hospital and non-hospital, which we refer to non-hospital registries, which basically includes everything that is not a hospital right now. So you have single hospital or multi-institution facilities. Like I said, El Sechel is one example. You have the American College of Surgeon hospitals. They are accredited by ACOS, and they have a requirement of having a registry. They also have a requirement of having CTRs, which are certified tumor registrars, so in terms of coding the cases and quality controlling the cases for the registry. Non-ACOS hospitals follow only certain guidelines or certain activities that are required for them, and they may or may not employ CTRs. They are really, well, I get back to that later, but they're really, because our non-hospital reporting sources or reporters increase, it is harder for us nowadays to keep quality up because those facilities, as I said, they may or may not have CTRs, they only do certain activities. So it becomes much harder if you have a lot of different sources of data coming into the registry. Then we have the specialized registries. So the brain, CB Trust Brain Registry, they collect benign brain tumors We do not collect benign brain tumors anymore. There's only very few benign brain tumors that are required to be collected in Central Cancer Registries. This one is nationally covering, pretty much covering. You have the Ovarian Familial Cancer Registry, which was founded by Gilda Radner. It includes, you can be included if you have two or more relatives affected by the disease. And then you have the Lung Cancer Registry, which is run by the American Lung Association. And you have the Colorectal Hereditary Cancer Registry at Johns Hopkins. So the Missouri Cancer Registry, as I said, you have central registries, you have hospital registries. So the Missouri Cancer Registry is a population-based central cancer registry. Our goal is to collect all incidents, so any newly diagnosed cases among persons that live in a specified geographic area. For us, that's Missouri. And the current level is over 95%, which is actually, last year we met 99%. So we, for the first time, have surpassed any other year that we ever collected cases. Now it changes a little bit because sometimes they change the formula and how they actually calculate your incidence for the state. Changes sometimes a little bit, but we've been with the activities, with the increased activities that we've done over the last year, we've reached this high level. You have the Missouri Cancer Registry last year applied for SEER funding to become a SEER core infrastructure registry, which we did not become the full SEER core infrastructure registry. We became a SEER Research Registry, which I show here in a minute what that really means on the map. It is extremely important, or it's very important for us to be SEER or become a SEER registry, as only SEER registries do full and active follow-up. And to become a survival registry and to be able to do research on outcomes, quality of life, and really look at, to reduce the morbidity, mortality, and do some more in-depth research studies, you have to have that data and not only have that public surveillance data that we are collecting. So here's the map of the SEER registries in 2021. As you can see, I don't know how good you can see it on the map. So the dark blue ones are the full SEER registries now. The middle blue or lighter blue ones are the ones that are research registries. We've been picked up as a research registry along with Colorado, Tennessee, Arkansas, and Michigan. So these registries, full registries were Texas, Illinois, and New Jersey. So like I said, one of our goals is to become a full SEER registry. And I think we're very much on our way. You will see later on all of our activities. So also to understand our database, our software and database tools, our CDC provided Registry Plus, it's called the Registry Plus Suite. It has CRS Plus, which is basically our database system. It holds over 1 million cases. We have Prep Plus, where we prepare cases. Web Plus, which is an online reporting system where you can report from anywhere. So all of our facilities now, especially the ones that we bring on as new facilities, we basically train on online reporting. EMARC Plus includes pathology reporting. And Abstract Plus is a standalone system that we give to some of our reporters that don't have very much capability, so they cannot really, they cannot run or cannot do the online reporting. It's installed on site. It might be a small clinic or somebody that still wants to report, but really cannot, get on the full online reporting. Link Plus is a program that you can use to link patients or to do linkages, patient linkages, also part of that suite. Missouri provides, the Missouri Cancer Registry provides customized software, which by customized, I mean our Abstract Plus, that we get that software from CDC, but we still have to actually customize it. We actually have our conversion going on right now as we speak. We've converted to our new version of Web Plus right now, and we are anxiously awaiting, Prep Plus and SEER Plus. So it's a lot of steps that are involved. But we provide a customized software to our over 170 reporting facilities. So it is quite an endeavor. We do it once a year because the versions change every year. Collecting cancer data, just like cancer data and treatment and cancer care changes on an ongoing basis. We have codes and we have a lot of different changes in a year that has to happen. So we have a yearly upgrade that happens. Like I said, for the new reporters, we basically use Web Plus. Are there any questions so far? No? Okay. All right, so just, I already kind of talked about this, but mission and goals for the Missouri Cancer Registry is really to collect all the cancer cases, complete, timely, and accurate for the state of Missouri. And we have our mission and goal also on our website. We'll look at we have a completely new website. So now I will go over the history of MCR and how the Missouri Cancer Registry came about. So the Missouri Cancer Registry historically was founded or started in 1972 by some visionary physicians that decided to put a voluntary agreement in place. And they had enough vision, I guess, to decide that we really need to have those cases. We need to look at the cases over time, and we need to be able to have them, bring them together in, I don't know if they had a database, probably not, but something like a database, probably paper reports. The state mandate was 1984, and that happened after the time-speech dioxin contamination that happened at that time. I have the video there, but I mean, we probably don't have enough time. But if you didn't hear about time-speech in Missouri, you should go look at it at least. I mean, you can find it as soon as you put time-speech in. It's a small town where they basically had a problem with, I think, dust on the road, and they decided, this is a very quick generalized overview, but basically they decided to solve the problem by pouring oil on it that was contaminated. And that oil then seeped in the groundwater, it contaminated the whole town. You cannot live in this area anymore. It's now a state park. But nobody is allowed to live there in that area. 17 miles away from St. Louis, close to Eureka. So like I said, it was one of the biggest contaminations, I think, that happened. So yes, based on that, our state mandate was enacted in 1984. And we were funded then in here's the timeline, in 1985, right? We were funded as a state registry. In 1999, we had in 1992, there was the Federal Cancer Registry Amendment Act, and that was funded federally or nationally 1995. Our reference year, this is also a very important, I guess, term for cancer registries. Our reference year is 1996. That means starting 1996, we have fully complete, quality controlled, and accurate data that you can actually request. So that's called a reference year. So if you ever request data from a cancer registry, even from another state, you ask, so one of the questions to ask is, what is your reference year? So that lets you know how far back they actually can guarantee that the data is research ready and can be used. In 1999, due to a change in practice, basically how physicians treated patients, we had the expanded reporting in Missouri for all the non-hospital facilities, long-term care facilities, physician offices, ambulatory surgery centers, which basically meant, and I will have a slide about this, but it basically is how you treat patients. So like there were around 2,000 people started to be seen in physician offices, and you could basically be seen in an office, be diagnosed in an office, and then maybe get a treatment in an ambulatory surgery center, radiation in a freestanding radiation clinic, and you actually had never entered a hospital during your first course of treatment. And we found that we actually missed a lot of cases. So for registries, CDC-funded registries and PCR-funded registries, we collect first course of treatment. So we found that, so that's led to that expanded law. In 2002, in 1999, some of the operations then, day-to-day operations, were moved to the University of Missouri. And we fully moved in 2002, and I wanted to say that it's actually our 20-year anniversary at the University of Missouri. So 2022. And then in 2021, we applied for, like I said, the SEER and became a research registry. So that's our timeline. And then this is just a quick slide about our funders. So like I said, we're funded by the National Program of Cancer Registries. We just received our new 5-year grant that was funded. We have a cooperative agreement with the Missouri Department of Health, and we also do some of the research projects, which there's only a few that are mentioned, but I have a slide on research projects, so I think we can talk about those. I want to mention that. So the last one, the VPR, is the virtual pooled registries, which is actually the virtual pooled registries were funded by the NCI, so by the National Cancer Institute, and they are coordinated by our national organization, the North American Association of Central Cancer Registries. It came together because they wanted to connect and basically let people effectively get or request data much quicker than what it takes if you actually request data. So like if you want to do a study across, let's say the region, right, the Midwest, you have to go to each state. Each state has different laws and a little bit of different regulations on how you request data and really how you can move forward. They have different, all different rules for their IRBs. Some of them have 2 IRBs. We also have 2 IRBs. We go through the University of Missouri IRB, and we go through the IRB at the state. So some of them have only 1. So like there's a lot of variety. So it makes it very complicated to do a study across state lines. So therefore, they have this virtual pooled registries where registries basically opt in. And then the process is run through that through the NASER organization, and they can request data much more quickly. They are very low risk studies, so if it still is a very complicated process if you want identified patient data. But this one, this is right now in the beta testing phase, and there were like, I think about 20 or 25 studies that have been now run nationally. I think one of them is nutrition services. The other one is a pilot one, and the other one is the 9/11 study for firefighters. So like there are national studies that where they possibly just want to do the first steps and explore what needs to be done or really what they need to look at. So some of the use of cancer surveillance data. So incidence data and trends is what we provide. We provide it to, through the Missouri Cancer Registry. We provide it or put it to the National Program of Cancer Registries. And we also work with, so our data is uploaded into the SEER registry system, where you can actually, through tool that is called SEER Reg, you can actually request data or look at data. And then the mortality. You also have the cancer surveillance and the cancer control programs that we provide data to. So they're all the programs at the state. We provide data to Show Me Healthy Women, which is also a state required program. And we provide data or work with the state if there's a cancer cluster or any cancer inquiry, like I said. So time speech, for example, would be a cancer inquiry. Then we participate in some of the research studies, and then we do other special requests. Some of them is called a next of kin request. If someone has, for example, a deceased relative, they can actually request data about their disease or about their cancer. And if there's any question or anything that needs to be answered from that side. These are just the statutes and regulations, and like I said, I already talked about the expanded law. So we have, it helped us to and gave us the authority to expand past hospitals and then have those additional facilities report to us, which includes pathology reporting. I mentioned that also, so the Missouri Cancer Registry has over 1 million records from 1972 to present. Our reference year, as I explained earlier, is 1996, so you can go back to 1996 to request data. We process over 60,000 records per year, and which result in over 37,000 unduplicated invasive Missouri incidence cases per year. That's what I was talking about. That's the practice change that I was talking about. So basically the change in medical practice, how patients were treated and how they were seen. It specifically affected the sites melanoma, leukemia, prostate, colorectal, bladder, and breast. So those sites were specifically where we actually found that we possibly missed some cases. Some of the other data sources, like I said, we are part of the national exchange, so the inter-registry case sharing agreement, which covers 80% of the United States. We also do death clearance and follow-back. So follow-back related to death clearance, not follow-back like survival. Death clearance is an annual process where we basically link with all the death data, the state death data, and see if we have any missed cases. Usually it's done around this time of the year before our annual data submission. And we also do data linkages with the federally, well, at the state with Show Me Healthy Women, but then with the SSDI, Social Security Death Index, IHS, which is the Indian Health Service, and the NDI, the National Death Index. So what I think what most people are interested in, what data are available. So we have the NASER data set. You also have, we have over 225 variables that are available, which more than likely you don't want, first of all, you don't want all 225 variables, but not all of those variables are at the 90% level or 95% level, but we have pretty much the major variables that you need for your studies, and I have additional, I guess, I'm talking about what the variables include here in a minute. You have the variables you need to do a study, and if you want to request data, you can request data on our MCR website. The website is listed there, and we will also go to the website at the end of our talk. But basically, you can request data on our website. directly from us, and you can, depending on what your study protocol is or what your study is, we'll walk you through how to request the data, what you need to do for the IRB, and so forth. Some of our challenges, like I mentioned, as we collect these very diverse data from and varied data from different sources, our quality goes down. So like it's a challenge. Pathology data doesn't have all the data that you get out of the electronic health record, right? If a certified tumor registrar sits in a registry and actually codes it and collect and make sure that everything is there and everything is filled out, we just get a pathology report, which is a very important part of our collection, but it's different. Or you have a very small facility that doesn't have the capability of actually, and doesn't even have the knowledge of really how cancer cases need to be coded. So the other thing is changes in reporting requirements. Like I said, they're ongoing. One of the examples right here is in situ cervical cancers that are currently not collected. We used to collect them. There's also additional required data elements that are continuously being added on. We have now, we have biomarkers, and I have another slide about biomarkers. We have site-specific factors that are continuously changing and that we have in the registry, and that, but it's a continuous change. We have modernized and updated the cancer registry greatly. This is one of our proud projects. So we are using Power BI provided through the University of Missouri. I just want you to look at the middle top tile. So basically where it goes down from 50 to 17. That's how quickly or how we have improved our reporting from when the case comes in to when it actually goes into our main database. Just through using dashboards and actually tracking that is done on an ongoing basis, and that you can actually look at while you're tracking and reporting those cases. So this is another one. We are, and I've blocked out the names of the hospitals, but we are basically on an ongoing basis looking at how they report their, depending on their numbers, they need to report quarterly, monthly, or every 6 months. But we can basically track this in an ongoing basis, which helps us greatly to meet our timeliness and requirements and our completeness requirements. Yes. The previous one?
Yeah, there was an earlier slide where you said that there was 37,000 a year.
Yes.
Is that what that roughly adds up to? If you added it all up in that top left, it would be about 37,000 roughly?
Well, it will be at the end of the year.
Well, at the end of the year,
Yes,
okay,
yes.
that's fair enough.
At the end of the year, we should be, that at the end of the year, those will be, so 60,000 records is what we basically process. And then looking at cases that are actually need to be reportable, and then cases that need to be consolidated.
So then it gets skinny down to.
Yeah, so they get consolidated because we, remember, we get cases from different facilities. So if the patient gets seen at different hospitals, at hospital and radiation facility, it becomes one record. So like, yeah, we do that. But yeah, these dashboards and basically looking at things and tracking things continuously has helped us greatly to improve. It actually, our facilities also have told us that it helps them. We do timeliness much more often on a regular basis. So where are we and what's next? We do have the data. We do have a lot of data. We do have quality control, and we have really, we are certified. We are certified at the highest level. We have good data. So our data is there to be used. Data management and data analysis is still a bottleneck. I just say that because it's an ongoing, continuous process to basically make sure that, like I said, with increasing reporters, to make sure that they all stay at the quality level that we want to give out if somebody wants to do a study, or if we want to actually follow and make sure that surveillance is done at the right level. So data science and informatics happens at every step. Like I said in the beginning, we have done informatics in public health for a very long time. So, and then to understand the patient in context is key. So we do have sometimes, problems with people. Well, the main problem is that researchers come and want everything, right? So like you don't want to request everything, you don't need everything, you just need, what your study question is or what you need to answer. So that's one of the questions. So you really need to understand your question and what data you need from the registry. And the next steps are really in the precision health area, and we have all the different data elements. That's what I always say. We have the data elements, so we'll look at those. Here's just a little slide, a little throw-in. It's basically how we want to meaningfully group our patients. We have biomarkers. We have the biomarkers. And we do have some of the behavioral data, and we have the risk factors for cancer, as most of you probably that are here and that are on Zoom are familiar with. Half of those we have in the registry. We have tobacco data, we have alcohol data, we have obesity, we have age, we have, so we have a lot of those that are listed. We actually have them. So we actually can do a lot more than we think, I think, that and that is done right now with the cancer registry data. So like anyone that, I invite you, anyone that has a idea or wants to work on any of those specific, in those specific areas, come and talk to us. So the future, electronic and web reporting capabilities, cancer registry data is always called it's old, because basically our data doesn't get released until 2 years after. It has to do with that the patient, it's based on the cancer patient. So 6 months after the patient enters the hospital has to report the case, right? So like after 6 months, when they have entered the facility is responsible to report. That's the first 6 months. Then it comes to us. We don't finish the case until we get all the information, so like which can be for any cancer treatment or cancer therapy that they're going through, which probably involves surgery, chemo, radiation. So it will probably be at least a year. So we're talking about already 18 months, and then we, including our work, it's really our complete data that is being released is technically being released after 24 months. The big work that is done in cancer registry right now, and that what everyone is working on, is real-time reporting. So like we want the cases to come in earlier, or like we want the data to be released earlier, so you can actually do the research much earlier. There's an increase in variety of data, like I said. We have different data like imaging data, pathology reports. There's an increase in the non-hospital reporting, so which is also, in terms of capabilities, it can be a problem. And then there's an increase use of data for public health practice and research. SEER research also, precision health, like I said, survival data. That's really what we are aiming for. And then the virtual pooled registries, like I explained earlier. Artificial intelligence and NLP. So we'll talk about this in a minute. We do some of that already when we are reading in our pathology reports, or like how pathology reports are brought in. There's some basic NLP that is being used in the program. Cancer registries, overall, our natural source of population-based genomic data and environmental and equity data. We have the different data variables and data in the registry. cancer registries collect from facilities that have additional information. So right now, equity is, or looking at really the full picture is it's required. Nobody wants to have only a little piece of, that you're looking at. We're looking at, if you're looking at health disparities or you're looking at equity, you need all the different data items, the different data variables, and we do have a lot of those in the registry. Do you have a question?
I will, go ahead and finish.
Okay. Okay.
It's all good, this is all good.
Okay, yeah, no, it's fine. I can take questions while I talk. So the Central Cancer Registries, we work with IRBs. We are very much used to working with IRBs, so like this is nothing new for us. Confidentiality, de-identification, all that is not new. So we are very familiar with this. Clinical and research registry. So like, what else can we do? So what do we do besides, or what can we do additionally with the collected data, right? So case ascertainment, which is extremely important to have to look at cases at an intensive level or the very focused level. So for example, we call it rapid case ascertainment for pediatric cancer cases, right? A lot of times for pediatric cases or for some advanced disease cases, you don't have a lot of time. So like after 24 months, that might not be in discussion anymore. So like it's very important that we have those processes that are possible where we do that rapid case ascertainment. And then again, survival statistics is extremely important. That's why it's important for us, I think, to on our next step should be going to SEER. We do have biomarkers in the registry. ERP or HER2, we have collected this for years already. This is nothing new in the registries. That's why I'm saying like, I think it's underutilized. Registries are underutilized. We have the data in the registry. And then registries can be used for cohort selection and identification. You can actually do the first step for your trials or for anything that you need. You can find if you have a cohort with enough people in the state or in an area that you're interested in. Can be hopefully soon we will be able to link to EHRs. We can link to EHRs already, but there's some other steps that need to happen at facility level. And then also recurrence data. So recurrence, we don't actively collect recurrence data. We don't get rid of recurrence data if we get it. We get it from the hospital. So all ACOS hospitals will have recurrence data. And they will report it to us because when they code the case, it's already there. We don't actively go out and get it right now because it's not part of our requirements. So for SEER, that would be also, again, very important. And there's a very much interest in getting recurrence data because with better treatments and with cancer care that's improving, we have a lot of cancer survivors. I actually had a different graph on here that ended 2020. So the number on the left is the 17 million is actually now in 2020. So we have over about 5% of the US populations are cancer survivors. So this population is growing. So as you can see on here, 26 million in 2040. So we need to be able to, we need to look at that, and we need to look at recurrence data because they will possibly get either a recurrence or they may get another cancer. So we need to be able to look at that. And it's also very important for some specific clinical trials or some specific disease that is very prone to recurrence, like pancreatic cancer, ovarian cancer, melanoma, or glioblastomas. So what are the possibilities? One registry is using the registry as an electronic path report repository that is linked with their virtual tissue repository. So there's options that we are very much interested in. And so you can identify cohorts, you can look at tumors for research, and then you want to integrate molecular profiles and electronic path reports, which we are already doing, to really have a common research data pool. So in 2021, we linked our whole database to 1 year of pathology reports. And we get, so pathology reporting, because it is electronic, we get over, I want to say, each month, we get as many cases as we are processing maybe for registries from hospitals for like 6 months. So we get a lot of pathology reports that we have to go through. And that's why, I hope this is AI, yes, okay, this fits. Okay, so that's why AI and artificial intelligence for cancer surveillance is actually really important, because you need to be able to process the pathology reports. There's some, a little bit of, it's still in the starting phase to really understand some of the artificial intelligence errors, but reading in and automating extraction from pathology reports is already being done, and it's we're working on that, and it's being used. So some of the artificial intelligence, so like I said, we work very collaborative as registries. There's some inter-state collaboration, and there's also some data sharing and model sharing that's ongoing. One of the issues is uncertainty, so it's very hard for artificial intelligence to handle uncertainty. At the Oak Ridge National Laboratory, that's basically what they're focusing on and what they've been looking at, and they call it the hope, the hype, and the hard truth. The hope is that this will work, right, so that we can actually use artificial intelligence much more in cancer surveillance, because it's a very labor-intensive process, expensive process overall. But what they found is some of the errors, it is harder to deal with. And one of the downfalls, which that's the hard truth, is that data quality is one of the problems for artificial intelligence. And then some of it has to do with hacking and vulnerabilities, but overall, this is where they are at. But we are moving in that direction, and it's definitely that's something where we want to be involved in it. Additionally, there's the integration of omics data that supports the decision making in precision medicine. So we want to have all the data available for the patients. Natural language processing, like I said, is we are using some of the methods very basic when we are bringing in our pathology reports, and automated methods to identify cancer patients for study recruitment should be probably used more because you want to make that available to the patients or to everyone that qualifies. And the check mark is because we do receive our pathology reports in real time. We do have that process now in place. And especially it's important for the patients that do not have enough time. So starting with this year, we're bringing in and starting our cases as pathology-only cases, which they come in first. So like I said, from the hospital, there's this delay, right? They don't have to report until 6 months after they've been diagnosed. We're bringing in those pathology reports. They're coming in as soon as we have them. As soon as we have enough information, we make it a case. And then we'll wait on, it will be consolidated with whatever comes from the hospital, and it will be, controlled or depending on what information we are getting. But we have that case much, much earlier. So we have that case basically, right now we're getting 2022 pathology cases. So, like I said, towards timely real-time reporting, that's really one of the big challenges in cancer reporting. And I'm on the NASA strategic planning work group that works on the next steps and the conceptual model to actually make that happen. Where's cancer registry, where's cancer surveillance going in the next couple of years? Federally, there's the Early Case Capture Initiative. They have started that specifically, like I mentioned earlier, for pediatric cases. There's the funding of electronic data sources from NCI. And then we have the Cancer Research and Precision Medicine that also supports rapid case ascertainment. And one of the limitations, like I just explained in length, is that it takes a little bit longer or until the full data report comes out. That's one of the limitations of the US cancer surveillance system. These are our studies that are ongoing. I missed some already. I noticed that when I came here. So like we have a medullary thyroid cancer study ongoing, the NCI transplant cancer match study. We have the young melanoma survival study, osteosarcoma study that's completed already. The sub-county project, which is looking at how you can show cases to the level, so it's actually more usable, but not compromise confidentiality. So like depending on, if you have a rural county that only has 2 cases, it can be shown right on a map. So like it's working on how we can deal with small numbers and how we can look at county level data. Then the PLCO cancer reporting trial, which is prostate, lung, ovarian, and colorectal, and some of the the NPCL study, and then we have the VPL, and yes, and data modernization. So I'm talking about data modernization. So the Missouri Cancer Registry was funded last year through the Data Modernization Initiative. Data Modernization Initiative is a $1 billion investment federally into public health departments and basically public health modernization. We finally, I mean, we all saw that our public health systems are not well funded and are not probably up to date. Their technology a lot of times is very much behind. So there's a large initiative, and for cancer registries, there was a specific data modernization initiative focused on cancer registries. We are one of 16 states that were funded, and I'm really proud to say we are one of 2 that were fully funded. So Missouri and Louisiana were the only ones that were received full funding for data modernization. Data modernization was funded for 1 year, and we've now been asked to stay on as testers, beta testers for the implementation or for some of that testing of what was actually accomplished through this last year. So we're very invested in this. It was a lot of work. It's looking at some of the putting data in the cloud and getting moving forward with some of the initiatives.
Who's the funding agency?
The funding agency is CDC. For you mean the $1 billion? That's federal investment money. So like it's overall CDC. Yeah, CDC invests into. There's additional there's funding for laboratories, for example. So laboratories are very much behind in their software and their technology. So there's a specific initiative that focuses on that only. The funding that we're going to hopefully be moving on and being added onto very shortly here is continuing this data modernization for cancer registries. So like it has, it's based on which area you're in public health, I guess. That's, I don't know if that answers your question. If you type, you will find it. If you type it in, there's a lot of opportunities for additional, but it's bringing public health to the level where we need to be. Hopefully, if there's another COVID again or something else happening. So Cancer data access, so there's MICA and MOFIMS, which is at the state. There's the MCR website. Okay, I'm almost done. There's the MCR website. There's CINA Plus online. These are all resources where you can request data or where you can access cancer data. The United States Cancer Statistics is actually where you has now includes NPCR and SEER data together. They have never done this. They have now put it together, so it covers the whole United States. And you have the Cancer Data Atlas. So let me see if I can skip some of this. Okay, so 5 to 10 years, yes. We want to provide other real-time statistics data, and I think I covered most of this. Yeah, actually, I'm at the end, okay. Yes, and the Cancer Data Atlas. So acknowledging our Missouri reporting facilities, our other Central Cancer Registries that we exchange data with, and then our extremely hardworking Missouri Cancer Registry staff and students. And then acknowledging our funders, CDC and cooperative agreement with the Department of Health. And then I wanted to tell everyone, come and visit MCR. We have a new location. It's the old human resource location, or in other words, also the last year, it was the student COVID-19 testing site. This is our new place. We've been here, we've moved in last June. And then I would, so this is my information, but I would like just to really quickly go to the website. If I can. I think, yes, perfect. Okay, so we completely overhauled our website. There's 3 buckets: education, cancer reporting on data. You can just click on it. If you can scroll just a little bit down. Yep, just a little bit more. And then, so a little bit more. So we have our, which we call the one-pagers, which is a requirement to basically, those are the top 6 cancers in the state. It's a summary or it's an infographic of those for the state of Missouri. And then if you scroll down a little bit more, those are our certifications. We just received our gold, our surveillance registry, disease registry, and USCS certification for this year. Any questions? Any more questions?
Yeah, great, Iris. So by state law, every hospital has to report all cancer patients to the state of Missouri?
Yes.
And you get all that information?
Yes, not only all hospitals, all facilities that either diagnose and or treat cancer.
So all the radiation oncology units in rural Missouri have to send all their data in. So
unless the patient is reported through another process. So like if they know they're getting reported by the oncologist or by their primary care physician, probably not. But,
so if we want to know cancer numbers in Marshall, Missouri, we can go to the database.
Yes. You actually would have that on, this is actually something
And what is the penalty if they don't?
So that's a really good question. We did for some time actually now think about one of the other changes to the law was that Missouri doesn't really have a law with teeth, so there's no penalties, no monetary penalties if you don't report. We've thought about to actually change this, but you actually have, you can go to licensing. We found out that you can actually, it influences the licensing if they are not reporting.
But they don't get any money to report the cases, so it's sort of an unfunded law that they have to report these.
Yes, but it's public health. So like it's basically, it needs to be done. It's like, it's like infectious disease. You don't really get, money to report infectious disease, but it has to be done. We need to know it in order to make decisions and in order to know where our money needs to be.
And so you're getting the genetic data too? If they
We are
have,
working on, this is our new initiative, so the new initiative, so we already get pathology reporting, we do have the authority, and we are starting to work with sequencing labs. Just like pathology reports, we can, they basically can send the data to us. It can come to us, so that's the next step is.
well, the sequencing labs send the data to the hospital or to the doctor.
Possibly, yes, and then it disappears in the EHR. Because I
You
tried to track that at one point.
It appears in the EHR in obscure places.
Yes,
I mean,
that's
is
what
the
I mean by
problem.
that. It disappears because if you're not the ordering physician, you will not know about
Yeah,
it.
my understanding is Dr. Waitman's team is trying to
Yeah.
standardize that, where it's going to sit in the EHR.
Right. So, and it needs to be in a place where if you're not only the ordering physician, but also anyone that treats that patient or has anything to do with this patient actually knows that they had a genetic test.
But how does the registry have data, have access to the EHR throughout the state of Missouri?
We don't really have direct access. Remember the cases are reported to us, so they come from the registry. So each registry, so Alice Fischel registry right here, gets their cases out of the electronic health record at MU. So
do you get, is the information that you get identified data?
yes. We have that's what I was saying, that's why I'm saying like we have the data.
Do you just get the path reports in the electronic medical record report, or do you get data that's already entered into a software package, or does your team have to enter it?
We don't really enter it. We get path reports come through, so most of them. There's very few that come on paper, but most of them are reported electronically, HL7 through HL7 through FINMS.
But who extracts all the data so that you can come up with those nice one-pagers?
Oh, we do that. That's our work.
So you extract all the data from all this?
Yes, I mean, if the case comes in, it goes through the process. We have to look if it's in from another facility. It possibly gets consolidated, and once it's consolidated, and we know it's one case, then that one counts as one case. It sits in our database for whatever 2020. This is a colorectal case now, right? So it counts as that case. So like
How many staff members do you have that are looking at all this Missouri statewide data?
So in the registry, we have, right now, we have 13 people, like 6 of them, between 5 and 6 of them are certified tumor registrars. We have a statistician, we have a database administrator, we have an informatics person that did all the nice dashboards, and we have non-hospital units. They're not necessarily certified registrars because they work with the facility. We have students that work with us from HMI that work with the facilities. I mean, there's a lot of it. That's what I'm saying. Technically, we should use the data more because it's costly, right? We're putting a lot of effort in it and we're putting money in it to actually collect the data. So we might as well, I think, leverage what we have and use it.
And there was a question kind of following up on what you just asked about. It was asking about the one pager, that it was 2014 to 2018. Is that just because it's published out there? Could they get more current data from asking you directly, or?
They will be updated very soon to 2015 to 2019. So like I said, it's 2 years behind.
Lag.
Yes. Okay. So we are now up to 2019. Okay. Our one pagers are not up to date yet.
Thank you.
That's one of the big pain points in cancer reporting and cancer surveillance is that delay of when the data actually becomes available publicly. Now you you can work with us on a study that needs more recent data. That can be requested. We have the data.
And by being the contractor for the state, do you have to supply an annual report to the state of Missouri?
So the website that I mentioned, MICA or MOFIMS, is that's the cancer data system where you can actually go on directly and you can look at, you can do.
So, yeah, I know you can look at the website, but you're not by the
That's our
contract.
data. Yes, what I'm saying, this is our annual report. We give them that data annually and then it's being uploaded into their system. All data that you see, that's what I always say to everyone, all data that you see that the American Cancer Society makes projections on, or data that you see in a map, or national data that you see where Missouri is represented, is cancer registry data. It comes, that we're the source.
Well, we got Dr. Hildebrand on here, his still
Okay,
image. I
great.
don't know if
Yeah,
did
great,
Kentucky
thanks.
have this, Dr. Hildebrand? And how do you think, now that you're leading the Cancer Center, how can the Cancer Center leverage this
Yeah,
data
I am glad
resource?
you can you hear me?
Not
Barely,
well.
barely. I
Barely.
was hoping to meet you, Dr. Hildebrand.
Yeah, so I'm sorry I cannot be there in person. Can you hear me now?
A little better.
Yeah. Okay,
Go ahead.
so first of all, my first exposure to the cancer registry was in Louisiana 2009, and the progress is amazing. I really applaud and congratulate you for the fantastic presentation. In Kentucky, we also have a cancer registry. We were on the map. We're not fully funded, but I think it's a very advanced cancer registry there as well. I think for me, the real importance is not only to learn about the cancer, incidents and outcomes in Missouri, but I think for the Cancer Center, how do we approach you best with specific questions on incidents in Missouri, maybe in our area, when it comes to really feasibility questions from the clinical trials office or
Yes.
clinical trials?
We can work with you directly. Actually, I have a request from Jacob. We have a request from Jacob on our desk that just is a little bit delayed because of our upgrade that we're going through right now. And we have our data administrator is, you can see now online. Nishan Jain is our data administrator is online. So we have a little bit of delay on that one, but Jacob's data request for the 26 counties surrounding Alice Fischel is on our desk, and you will get that data very quickly, very soon.
And how do we file this request to you? Through the website or email you?
Any way works. We will have very soon, the website will have an electronic process that we use, but you can call us, you can email us. Jacob just called me last week or 2 weeks ago. So anything works. We're here, like I said, come and visit or just contact us in any way. We're ready to help, happy to help.